At the cellular level, diabetes mellitus creates a biological paradox. The bloodstream is flooded with energy, but the cells surrounding it are starving. Glucose piles up in the intravascular space, hyperabundant and readily available, yet it remains completely locked out of the intracellular space where it is actually needed. Blocked from its primary energy source, the body is forced into a severe catabolic state. Adipose tissue breaks down fat, and muscle tissue degrades its own proteins. The system starves in the middle of plenty. Under normal conditions, the body maintains equilibrium across this cellular barrier using two distinct hormones, insulin and glucagon. Insulin works to reduce blood glucose. It binds to cell membrane receptors, which triggers internal vesicles to deploy glucose transporters to the surface, opening the gates for glucose to enter the cell. Glucagon executes the counter-regulatory role. It raises blood glucose by commanding the liver to generate new glucose molecules and to break down stored glycogen, dumping it all back into the bloodstream. Diabetes occurs when this delicate hormonal axis mechanically breaks down. Whether that physiological failure comes from the physical eradication of the cells producing the hormones or a widespread peripheral resistance to their signals, dictates the exact nature of the life-threatening crises that follow. The origin point for this failure lies in the pancreas, specifically within clusters called the islets of Langerhans, where beta cells manufacture insulin. In type 1 diabetes, the mechanism of failure is a physical destruction model. A genetic abnormality linked to HLA-DR3 and DR4 genes causes a loss of immune self-tolerance. The body's T cells mount a hypersensitivity response and systematically dismantle the beta cells. This eradication forces a complete halt to insulin production, resulting in an absolute insulin deficiency. Type 2 diabetes operates through a peripheral resistance model. The pancreas remains intact and produces insulin, but the target tissues develop a mechanical resistance to the signal, with insulin molecules simply bouncing off the receptors. Even with normal insulin levels in the blood, tissues fail to move glucose transporters to the cell membrane. The intracellular gates remain completely shut. To overcome this resistance, the pancreas attempts to compensate. Beta cells increase in number, hyperplasia, and grow in size, hypertrophy, pumping out massive amounts of insulin to force a physiological response. This hypersecretion triggers a toxic tipping point. Along with insulin, the overworked beta cells overproduce islet amyloid polypeptide, or amylin. As this amylin aggregates inside the islets, the beta cells become exhausted. They shrink in size, become dysfunctional, and eventually undergo apoptosis. As beta cells drop, the body is left with a relative insulin deficiency. Circulating insulin is simply not enough to overcome the dense tissue resistance. Autoimmune eradication in type 1 and mechanical exhaustion in type 2 set the stage for severe, albeit completely different, systemic failures. Despite these distinct origins, both etiologies converge on 4 classic clinical symptoms, driven entirely by fluid dynamics and metabolic physics. The first is polyphagia. Because the cells are starved of glucose, systemic lipolysis and protein catabolism drive intense, continuous physical hunger. The second is glycosuria. As extreme hyperglycemia exceeds the renal transport maximum, the kidneys fail to filter the volume, spilling glucose directly into the urine. Because glucose is an osmotically active polar molecule, it acts as a solute, physically dragging water molecules along with it through the renal channels. This osmotic pull massively expands the fluid volume in the tubule, resulting in polyuria, or massive frequent urination. Finally, this constant loss of water depletes the intravascular volume, triggering severe systemic dehydration and the extreme thirst known as polydipsia. These shared symptoms are a mechanical illusion. They represent the body's baseline reaction to trapped glucose, masking the entirely different biochemical crises about to unfold. The severity of the acute crisis hinges entirely on whether that insulin deficiency is absolute or relative. In type 1 diabetes, the absolute absence of insulin removes all inhibition on lipolysis. The breakdown of fat runs completely unchecked. The liver converts intercepted free fatty acids into highly acidic ketone bodies. These flood the bloodstream, rapidly dropping blood pH and causing diabetic ketoacidosis. To buffer this acidity, cells absorb excess protons, swapping them for potassium ions ejected outward into the blood. Without insulin, sodium-potassium pumps stall, stranding potassium in the blood and triggering hyperkalemia. In type 2 diabetes, residual insulin suppresses extreme ketogenesis, avoiding severe acidosis. Instead, astronomical blood glucose creates an extreme hyperosmolar gradient, aggressively pulling water out of adjacent cells, leaving the intracellular space severely dehydrated. When this severe intracellular dehydration strikes the brain, it physically shrivels the neurons, causing profound mental status changes. The physiological endpoints are distinct. Diabetic ketoacidosis threatens the body with severe systemic acidosis, while of failure. The exact mechanism of the breakdown dictates the medical response. Standard diagnostic thresholds confirm the disease's presence: a fasting glucose at or above 126 milligrams per deciliter, or a random glucose at or above 200 milligrams per deciliter. To assess the chronicity of the hyperglycemia, clinicians look to glycated hemoglobin through the HbA1c test. When glucose concentrations remain high, the molecules permanently bind to the proteins in red blood cells. An HbA1c of 6.5% or higher provides a 2 to 3 month historical average of serum glucose, neatly bypassing day-to-day fluctuations. To differentiate type 1 from type 2, the crucial diagnostic tool is the C-peptide test. During endogenous insulin synthesis, the pancreas produces proinsulin, which then snaps apart into a functional insulin molecule and a detached byproduct called C-peptide. Because C-peptide is only created when the pancreas produces its own insulin, a low or absent C-peptide definitively confirms the beta cell failure of type 1. A normal or high C-peptide indicates peripheral resistance and active pancreatic compensation characteristic of type 2. Beyond the immediate acute crises, chronic compartmentalized starvation extracts a devastating long-term systemic toll. Constant exposure to elevated blood glucose heavily damages the body's microvasculature, specifically targeting the arterioles. Through hyaline arteriolosclerosis, rigid protein deposits build up inside the arterial walls, making them increasingly narrow. Deep in the capillary beds, the basement membrane thickens. This physical barrier obstructs oxygen molecules from diffusing into the surrounding tissue, causing localized hypoxia. This precise mechanism of oxygen deprivation manifests in several ways: retinal cotton wool spots, glomerular damage in the kidneys, and stocking glove peripheral neuropathy. Simultaneously, this widespread vascular trauma accelerates major macrovascular damage, sharply increasing the risk of atherosclerosis, myocardial infarction, and stroke. Effective clinical management reestablishes the flow of glucose across the cellular barrier, restoring the precise physiological communication between intravascular supply and intracellular demand. Achieving that equilibrium demands targeting the specific mechanical failure, replacing the missing signal entirely for type 1, and strategically overcoming the tissue resistance in type 2.